some of this will dovetail, I think, nicely from Caleb's talk. He laid some nice foundation talking about stigma. So my talk will be a little more focused on just sort of the details of what happens in methadone clinics, now called OTPs, opiate treatment programs. In the Seattle area, there are three different networks. There's Evergreen Treatment Services, there's THS, Therapeutic Health Services, and CRC, Acadia, and there are probably in Washington State around 23 opiate treatment programs. And again, OTPs, opiate treatment programs, they're fairly highly regulated. We answer to about 12 different regulatory bodies. And it's, as Caleb pointed out, it's the only place where patients can receive methadone or Suboxone for replacement therapy. In no other setting can a physician, a PA, an NP prescribe methadone for replacement therapy. In fact, we don't prescribe methadone for opiate therapy. It's a fine distinction, but an important one. Opiate treatment programs order the dispensation of methadone. So nobody can legally prescribe methadone for replacement. Now, the scenery has changed greatly with Suboxone, because Suboxone, it can be prescribed both inpatient and outpatient, but methadone is much more restricted. And in our place, it's mostly methadone. Maybe 95% of our OTP patients are methadone, maybe 5% are Suboxone. And I'll talk a little bit more about that, because it's really an interesting thing about how many of our patients are profoundly uninterested in Suboxone. And I don't fully understand it, but I'm learning more about it. Approximately 16,000, maybe more, maybe less, King County individuals with opioid use disorder, with about 3,000 treatment slots. That was 2014. So there's a big mismatch right there. Not that all the 16,000 want to be in opiate treatment, but if they did, they wouldn't be able to. And if you look at the US, maybe 260,000 patients in opiate treatment programs. So this is the profile of who our patients are. Half of them are men, half of them are women. At my clinic, we have about 1,500 patients. We're down by Safeco Field in Seattle. And our dispensary is open every day from 5:30 until 1 o'clock. After 1 o'clock, lots of things happen, but just not in a dispensary. And so running up to 1,500 patients through our clinic in that time, it can get really, really crazy and really, really crowded. 64% white, 19% African American. Now, one thing that's not on here, one group, is Asian Pacific Islander, and I think that's because at our place we see very few of that demographic, which is interesting. One of the problems with our clinic is we don't have interpreter services. We struggle with phone interpreters, but we don't do a very good job with patients who don't speak English, and it's a bane of our existence. And we've worked and are working hard to try and find a way to fix that. But it really is an obstacle for many patients. You know, we sometimes make do because we'll have some of our staff speak Spanish. We'll drag them into the room, or family members, all the things that are completely not acceptable in the world of translating, but that's what we do. So how much does it cost? I think $100 per gram is pretty normal. Our patients, I think, like all citizens, or many citizens, many of our patients see themselves as good consumers, and they sort of take pride at getting good deals on things. You know, some people will say, I never shop retail, I would never pay retail for anything. Our patients sort of have that same sort of American idealism about being a consumer, and many will say, well, you know, my friends pay $100 a gram, but I get it for $50. You know what I mean? Because they know somebody or something. So it's really interesting. But I think $100-ish per gram is what they pay. I would say most of our patients don't work. So where do they get $100? If they're using 2 grams a day, where are they getting $200 a day? I mean, your imagination can take you to many places for that. Okay. So they pay by the month. We thank whoever needs to be thanked. We don't have to do billing. That's one of the things I love so much about working there, because I worked in other places too, where, I mean, you all know the fun of billing, whether you're doing it electronically or on paper, and figuring out what the charge is based on what you did. I mean, it's no fun at all. And it's one of the great things about working there, because we don't have to do that. It may change in the future. There's a move now to have more integrated services in opioid treatment programs, to bring in mental health, bring in primary care, and as that movement comes forward, I'm afraid with it will also come having to bill. But basically, our patients, they pay $500 a month. I think most of them are on Medicaid, and all of our Medicaid patients are very nervous about where that's headed as far as Medicaid funding. But most of them are on Medicaid. We have some private payers. Most insurance companies pay for opiate treatment programs, but that doesn't really count for many of our patients. Most of them are Medicaid. So $500 a month, I think it's one of the best deals in medicine. They get medical, they see PAs, NPs, MDs. We do a assessment, an exam at the beginning. We see them yearly for a general medical update, labs, UAs, counseling. We do some limited psychiatric services. We have 2 psych nurse practitioners who work there who mostly don't do psych services, but they do some. And we also, our medical director is a psychiatrist. His name is Paul Grecken. He's an addiction psychiatrist. So there's some psych services there, but not so much. And that's changing now for the good, because more and more behavioral health organizations, which are emerging, are collaborating and working out of opiate treatment programs. So this is very important. So how does it start? When they come in, the first thing they do is they have to go through a grueling 2-hour psychosocial assessment with a intake counselor. And basically they're asked about 9 million questions. But that's step number 1. And after the assessment, if the intake worker thinks this person is a candidate for admission here, then they're assigned a medical provider, like myself. At my place, we have 6, 3 NPs, 3 PAs, and a medical director. And then we see him for medical intake. The induction world in methadone has changed greatly over the years. I first started working in methadone treatment in 2000. And at that time, we would do the medical intake. Basically, the person has to meet DSM criteria for now, opioid use disorder. It used to be opioid dependence. And if they meet that, we also very much like for them to be in withdrawal. That makes us feel much better about starting somebody on methadone, even though it's sort of cruel to require that. But mostly we need to see some withdrawal. So if they meet the criteria, we think they're a good candidate, we admit them, and we start them with dosing that day. And they start off coming in 6 days a week, and we're closed on Sunday, so on Saturday, they get their dose and they get a take-home. It's liquid, comes in a little bottle. They go into a vestibule, which looks like, has a very much of a confessional kind of a feel to it. So it's just very, very, very fitting in some ways for what we do. And so we admit them at, the standard induction is 30 milligrams of methadone. And it's almost never less, unless somebody's been in treatment before and they were maintained on 20 or something. Obviously, we wouldn't start them at 30. We have a patient who's been coming to our clinic for 20 years at least. They do really well. They have a lot of take-homes based on their high performance, and they're maintained on 10 milligrams a day of methadone. So it varies, but we start at 30. When I first started there, the induction order would be patient starts at 30 milligrams, increase 10 milligrams per day until they get to 70. We'll see them back in a week and go from there. And we weren't knocking people off. I mean, it seemed to be an effective way to do it. But there have been numerous expert guidelines that have come out in the last 5 years, which basically said you can't do that. So now it's really changed. Now we admit them at 30. We see them once a week for dose evaluations. They mostly go up at any time is 10 milligrams. So average dose there is, average stable dose is between 80 and 100, some way higher, some way lower. But if somebody's going to go to 100 milligrams, it can take 2 months to get them there. There are some things we do to make it more speedier, like we do what are called peak dose evaluations. Or in the first week, patient comes in, takes 30, we tell them come back in between 2 and 4 hours later, because that's the peak of the methadone dose each day is between 2 and 4 hours. So it's called a peak dose evaluation. Yes?
At what point do you do EKGs?
Let me get there. I will. That's a great question. I will get there. So peak dose evaluations can hurry the thing up. But we lose a lot of patients because it takes so long. Patients come in, they're motivated, ready to go, and 6 weeks later, they're still struggling trying to get to a dose that's going to really allow them to stop using heroin. So a lot of people just walk because they just don't have the patience for that. And that's a problem with the new pace, but we have to do that, so that's what we do. The question was about EKGs. So as most of you know, methadone is like many medications, is a risk factor for increasing the risk of having long QT. A long QT is related to, which worst case scenario can result in something called torsades, which you know of, and it's basically a heart rhythm problem, and it's rare, but if somebody has it, they can die. It's really serious stuff. So methadone is one risk factor. We don't do EKGs on every patient because of that risk factor. We look for a second risk factor, and when they have a second risk factor, then we do annual EKG monitoring, maybe more. Also, so the second risk factor would be dose over 150, sort of an arbitrary dose, but that's what we've come up with. Personal history of having MI, a family history of having somebody die of a myocardial infarction, mother, father, brother, sister. So that's what we do. And I think it's a pretty standard protocol these days in methadone clinics to not do an EKG on every patient. Okay, and I would say our non-heroin admits, up to 3% maybe, people who are coming for other reasons besides heroin, other opiates. It's got to be an opiate. We do opiates. Oops. So dose determination is complex, and it's got lots of political and medical issues, and in past years, some states, and I think some states still do that, they have dose limits. You can't go any higher than 80 milligrams, for example. So it's a very difficult thing to determine. But we really use the big three, and we tell the patients this: don't get focused on the number as we're trying to get you to a dose where you can stop using heroin. We'll know we're there when three things happen. Number one, you're able to stop using heroin. That's hard because some patients will settle for, well, I'm using less. I was using every day before, 2 grams a day. Now I'm using twice a week for a gram a day. So they'll just settle for that. So it's a challenge to get patients to say, do not settle for that. We have to make this work, and for you to go through all this work, let's get to zero. So 0 heroin use, one way you know you're there. Second one is not having to battle through cravings and withdrawal all day long. That's another way people know they're there. And the third one is not being sedated or over-medicated. So those are the big three. Those are the 3 things we're looking for. And those are what we tell our patients when they say, how will I know when I get to the right dose? That's the answer. And some will come in and say, well, my friend told me I need to get to at least 100. And it's hard to disabuse our patients of that sort of focused on a number. But we try and do that. Subtherapeutic dosing, I think is common in methadone clinics. And like I said, there used to be more limits about how high you could go. But that's less and less true, as I think the field of opiate treatment medication-assisted treatment has become much more open to evidence. But the evidence in methadone treatment is still few and far between. There are some landmark studies about its effectiveness, and I think it's been proven. But it's a very understudied arena. And I think there probably are a variety of reasons for that. One is methadone is very inexpensive, and so the medication, so that sort of rules out big pharma as being interested in studying our patients, because methadone is incredibly inexpensive. So this, I think, is I don't know, it took me 5 years to really grasp this, and so it's still challenging to me. But the bottom line is that when you look at methadone, serum levels are not always an effective way to know what's happening. I know that in old school, maybe 15 years ago, some clinics, not ours, but some clinics would say if a patient came in and said, I don't think my dose is where it needs to be. I want a dose evaluation. They'd say, well, okay, we'll have to draw serum levels to prove that you need it, and you have to pay for it as well. So you'd have to do a blood draw, big expense to the patient. So the patient would just be like, forget it. I'll stick with my suboptimal dose. I don't want to go through that. But what we know now is that serum levels are not an accurate reflection. You can have somebody at an incredibly high serum methadone level who's in withdrawal. And you can have somebody at a serum level half that high who is profoundly over-medicated. The reason is that methadone in the US, as opposed to Europe, methadone here is called racemic methadone. And basically it means it's about stereoisomers. It's a stereoisomer thing. And there's an R and there's an S. And if you know much about stereoisomers, so methadone is half R, half S. What turns out that the only real active part of the racemic methadone is the R. The S doesn't really do much other than just take up space in that molecular composition. And some people metabolize the R thing at very different rates. Some people metabolize it very slowly, some very quickly, which is why you can't really objectively measure if someone needs more methadone based on their serum methadone levels. That's why you have to do a good exam, a good history. That's really where the rubber meets the road. In Europe, there's more use of just the R. And I don't really understand why we don't do that here. There's been some studies that show that you get much more bang for your buck with the R. So I don't know where this came from, but I know it's true. In the US, it's racemic, R and S. And we talked about the big three as far as advising patients about how do they know when they're at the right dose. When people come into treatment, they come in on one of two tracks, if I could use the word tracks. They come in on either a 6-month time limit or no 6-month time limit. And the 6-month time limit in regulations is called a 180-day detox. So a patient will come in with a 180-day detox status. So first of all, the terminology detoxification for methadone treatment is completely medically wrong. I mean, if you believe that methadone is a medication that people take for their chronic illness, then it's not a toxin. I mean, so when you taper somebody from insulin, you don't say we're going to detox you from your insulin. So it just kind of shows some of the stigma that Caleb was talking about just how we think about it. But the people who are coming in for the 6-month time limit, they're on a 6-month time limit because they have no documentation or no evidence of opioid use disorder for more than a year. So if they started using heroin 6 months ago, or 9 months ago, or 11 months ago, they're on a 6-month time limit. So what happens for these people, even when they do really well, they come in, they get really stable in their dose, but at the 4-month mark, their taper starts for a 2-month taper, so then at 6 months, they're discharged. And some of them who have the will and determination come right back into treatment the next day, but then we have to start over again, and so it can take 2 months to get them back to where they were. And so it's crazy, but it's what we deal with. And I think it's really a artifact of a weird way of thinking about methadone. If they have lots of scarring, for example, they come in, they don't have no documentation, no addiction, no diagnosis anywhere, but they've got abscess marks all over both arms, the medical provider can say, in my opinion, this is evidence of addiction beyond 1 year, of injection drug use beyond a year, and we can move them to the no time limit. Now, as Caleb said, the evidence shows that, well, people sometimes will say, well, does methadone work? I mean, are people, and our question often is like, what do you mean work? For us, methadone being effective means they're not using heroin. That is our goal. And the data is very clear in showing that the longer people stay in treatment, the less likely they are to die from heroin and opiates. We know this is true as well. It doesn't mean people have a life sentence in methadone just because they have opiate addiction, but some of our patients have been in treatment for 30 years and will be there till they die. And patients will say, well, how do I know how long I should stay in treatment? And really the answer is people who should be in methadone treatment or Suboxone treatment are people who can't stop using heroin or their other opiate any other way. Because if you could, great, do that. Why would you come to methadone treatment? Then the question is, well, how long should I stay in treatment? I mean, do I have to stay for 3 years or 5 years? And I think the answer is, again, people who are in long-term opiate treatment, medications treatment, methadone, Suboxone, those are the people who can't stop using heroin any other way. And sometimes you don't really know if that's you or not. The patients are like, well, how do I know if that's me? And the answer is, well, we'll find out. If you taper and you can stay off methadone, great. Stay off opiates, great. But if you taper, get out of treatment, and return to heroin use, then you're probably in that other category. Like Halo said also, there's this, although I think it's broader than just opiates, people who do well in treatment, they're like, I feel really great. I want to get off this stuff. It's sort of a backwards thinking. But I see the same thing with people who are on antihypertensives. And they achieve great blood control, a great BP control. And so oftentimes they'll say, I'm doing really well now, so I should get off this medication. And I think that gets to people's general ambivalence about medication in general. People, I think, I feel the same way myself, are rightfully ambivalent generally about medication, particularly taking medication for any kind of chronic condition, diabetes. Any of you who work in primary care settings know the battles you have with getting patients to do what we ask them to do with their medication. And I think that gets at a general ambivalence about medication, which I'm sure you've seen. So the pharmacology of methadone, as we all know, it's slow. It's slow to get to where it's going, and it's slow to get back down, which is one of the reasons why it's so dangerous as far as pain medication prescribing. You start somebody at too high of a dose, or you make too big of a change. Day 1, they're okay. Day 2, they're okay. Day 3, they're a little sleepy. Day 4, they're really sleepy. Day 5, they're dead. That's a kind of exaggerative look at the process, but it's possible. That's one of the things that makes it really good for methadone treatment is that it's long acting, but it takes 5 days to get to where you're going, and 5 days the other way. It has each day, it takes 20 minutes after the patient takes methadone for them to fully absorb that particular dose. And then from there, 2 to 4 hours until they reach the peak that day. So if somebody vomits their dose, which happens, people are sick or not feeling well, whatever the case is, it's a challenge because if someone vomits their dose, they say, I'm not feeling well, we require them to let us watch them vomit. If we can, say stick around, and if you feel sick, get back in the dispensary, because we need to watch you vomit. We need to see what time it is, and then how much we replace of that dose is based on how long after they took their dose. If they took their dose at 10 a.m. and they vomit at 10 a.m., that means we'll probably give them replace 50% of their dose. So if they vomit, so that's the deal. It's kind of weird, but to ask people to let them watch you vomit, but that's what we do. It's kind of unusual in medicine to do that. Okay, with 2 to 4 hours to peak each day. One of the nice things about methadone, it's decreased euphoria compared to other opiates. It's thought to have less euphoria. And the analgesia question is really interesting, and it's never solved. But the literature concludes that for people in methadone treatment who are there to replace their opiate, that after a short period of time, they'll get very little analgesia from the methadone. They become tolerant to the analgesia from the opiates. So a lot of patients will swear that, oh, this method, not only do I'm not using heroin, but my arthritis is really a lot better. And maybe it's true, but the data says that's really not the case. And when this becomes a problem for our patients is when they go to the dentist and they have 5 teeth taken out. And the dentist says, well, you're methadone treatment, right? You 80 milligrams a day of methadone, so you don't need any pain medication for your extractions, which is completely false. And so we have a little letter we give the patients which basically makes the case from our medical director that this patient receives no analgesia for methadone. But some of our patients will say, I'm not going to give my guy that letter. They'll like run as far away from me as they can. So it relates with stigma as well. But pretty much the belief is people in methadone treatment don't get very little analgesia from their methadone dose. Hep C, obviously very common with people in opioid treatment. These numbers are, I think sometimes they change a little bit, but they've held up pretty much. Up to 80% of them of IV drug users acquire Hep C, and of those, up to 85% will never have any problem with their Hep C, but 15% will. And of those 15% who do, many of them get very sick and many of them die. So when you have Hep C, I mean, the numbers are pretty good. Based on this, the numbers are pretty good that you're never going to have a problem. You're never going to get sick from your hepatitis C. But 20% is still a lot of people. We don't test everybody, but we offer everybody screening. And we have a screening program. It's called the Hep C Project. They come in, they're there 2 days a week. They do a finger stick. If it's positive, then it's a positive screening. And then we can refer them to what we now have 2 days a week, which are Harborview Medical Center primary care providers who come and see patients in our place. It's so great to have that. And so then we can refer them to them and they can initiate the Hep C workup. So, and that's new. Again, that's part of this whole integrated care thing, putting behavioral health organizations and primary care services housed within opiate treatment programs. It's far overdue, but it's really a great thing. Everybody, I think, knows this, but I still think that even within the medical community, there still is a lot of implicit, like Caleb said, skepticism about whether this really is a brain disease. This has changed a lot. In my 17 years of talking about methadone treatment, back even 17 years ago, a lot of people were like, no way, you're just letting people off the hook when you say that. It's a personal choice, etc. And I still kind of smell that sometimes when I talk with people, but it's kind of been driven underground, or else they don't have it anymore, the belief, medical providers, which I think is a good thing. I think a lot of medical providers, the vast majority, now really get and buy into the fact that this is a brain disease, this is a chronic medical problem, akin to many other chronic medical problems. But there's still some skepticism about it. And so it's changing, but it's still there. I mean, do any of you see that in your settings? If you have a chance to work with people with addiction, do you see any skepticism amongst our medical colleagues about whether this really is a disease or not? Or do mostly you see that people have really bought in and that there's concurrence about that? The data is super clear. Again, this may be unnecessary in this crowd, about addiction being having a genetic component. Twin studies, I mean, it's extremely genetic, and certainly sometimes in our exams, when we do histories with patients, family histories. I mean, it's like my mom's addicted to heroin, my father died of alcohol, my brother's in treatment here. I mean, you see that a lot. And it's just it becomes very, very clear. I think one of the challenges with people who are trying to stop using heroin is getting them to try to interact with people who don't use heroin, because that's one of the hardest things. If you're in treatment, it's going great, but everywhere you go, it's all your friends and they all use heroin. It's very difficult. So that's a hard thing for patients to do, because they have to sometimes say goodbye to their friends of their whole life, or sometimes they have to say goodbye to family members. Patients many of our patients have described starting using heroin with their family, with their mom. And so at some point they reach the decision point, like, for me to get better and to not use heroin, I have to like walk away from my family, from my mother. And that's I mean, think of the challenges of that. You know, I think the chronic illness model, which more and more people buy into, look how coronary artery disease is treated, or lipids, or diabetes, and they're treated very differently. This is one of the most difficult challenges that I have in being in this field. It relates mostly to our regulation and our regulatory bodies, but there are many things about the OTP model which are not medical. It's not really a medical model that you see anywhere else to tell somebody that if you miss 10 appointments, then we're going to kick you off treatment. Or if you have ongoing positive UAs, then you have to go on a taper. It's not a medical model. And it's a challenge for me, I think, and other providers to work like that. And it's one thing we've done to make it better. We have a very progressive medical director. He's really a great thinker about methadone. He's been in the field forever. But it used to be when I was there, if you had 9 UAs in a 12-month period, then you had to go to team. And usually when you go to team, bad things are going to happen to you as a patient. Team is like there's a counselor and a provider and a nurse, and so you meet, and they'll put you on a contract. And the contract used to be, okay, you've had 9 positive UAs in 12 months, so we're going to put you on a contract. If you have 1 more positive UA in the next 3 months, then you have to go on a taper. And of course, they would always have a positive UA in the next 3 months, and then they go on a taper. And we've changed that. I think some other clinics are too, but still, I think it's the norm to still do that, to discharge people for positive UAs. And so we no longer discharge patients for positive UAs. What we discharge patients for is if they miss 12 appointments in 60 days, we discharge them because that's 20% of the time and it's not going to work for them. If they can't leave at least 8 UAs in a year because that's what the law requires us to get, then we can discharge them. If they show up impaired, we don't tolerate that. It's not fair to the patients who are working their butts off to do this. So if they show up impaired repeatedly, we will taper them. And if they have behavior problems, yelling at staff, getting in fights, bringing a knife to the clinic, whatever. So those are the things that will get you discharged. Positive UAs will not get you discharged. It may intensify your treatment. You may be required to do more groups, but we no longer discharge people just for positive UAs. And I think the evidence supports that as far as trying to keep people alive. One of the interesting things about methadone, which you probably know, maybe you don't, it is a NMDA antagonist. And other NMDA antagonists are clonidine is also an NMDA antagonist, but it's thought that may attenuate or even reverse tolerance to methadone, because generally speaking, in methadone treatment, people get to a stable dose, and that's where they stay. You don't see the up and up and up and up and up. You don't really see tolerance to methadone, and the belief is it's because of its NMDA antagonist properties. Some people do. Some people 6 months. I've been at 150 for 6 months. Now it's not working. I relapsed. So some people we do have a little tolerance, but usually we don't, which is a really great thing to not have to just go up and up and up. I know in Europe there's some use of long-acting morphine in a OTP setting, and I'm struck by the fact that they must have a lot more tolerance, and that's nice that we don't. There's lots of mythology about methadone. One of them that it's a Nazi drug. I mean, it did come from Germany, but the first brand was Dolophine, and the first name was Dolophine, and some people thought it has to do with Hitler, the Dolph part, but in fact it doesn't. But there are some people who really still think that. They have this, some of our patients have this negative belief that it's got some sort of connection to Nazism or something, and it doesn't. The emergence of methadone, 60s was when it was Some good research was being done at Rockefeller. Then Neiswander and Dole, who were physicians who were pioneers in exploring the use of methadone for heroin, for get people to stop using heroin. During the Nixon administration, big expansion. I mean, I don't know where it came from, but somebody, I don't know if it's him or his public health people, but there was a big expansion of methadone treatment during Nixon's time, which I think is pretty cool. So we know about these validated claims here. Like, for example, it's cost effective, it's cheap, criminal behavior goes down. And that sometimes is the way to get public buy-in. Sometimes people in the public will be they don't want a methadone clinic in their city. And that is one way to appeal them, is like, where do these patients get the $200 a day? And the answer is, oftentimes, they get it from me, from you, from crime, from petty crime. There's lots of ways that's what they do. And that's an appeal that often is a winning appeal, even to skeptics, is to show them how it's in their interest to get these people into treatment. We have, lots of people are really creative in how they give money. This one person told me about this thing they did where they would go to Home Depot and they would, buy a $40 drill or something, and then they would pay for it, and then they would leave, and then they would come back in with the receipt, but without the drill, and then they would walk out with the same thing. And so, and then they would sell that, and basically they could return both of them. And so some of our patients are really creative as far as have to be, because when I'm also struck by, we have a lot of patients who, when we say, well, what is your income? Do you have any income? And a lot of them say, yeah, I'm a SSI or SSD, I have a disability. And we'll say, what is your disability? And they'll say, I don't know. A lot of them don't know what their disability is. And I don't think that makes them bad or stupid people, but it's just a weird system that they can't even tell you what their disability is. It's usually predictable. Like one person the other day told me, I have carpal tunnel, or I have back pain or PTSD or whatever. But I think a lot of our patients have been sort of trained or somehow to think that this is the way to live their lives, is to get disability, and it's hard to break that. We can skip that. Data, this is kind of old, but I think it's still true. If you compare someone in methadone for 6 months versus drug-free treatment, the ones in methadone treatment do a lot better. Also, this shows that dose is a related issue, and when patients are at higher doses here, up to 80, that they do better in treatment, they stay longer, commit fewer crimes. Well, interesting thing about methadone is P450, P450, and methadone is a inducer of a couple of substrates in P450. So like rifampin, for example, if someone takes rifampin, it can actively decrease their methadone dose by up to half, but it's never predictable. You just got to pay attention. So some medications can interact with methadone in that way. So that's something we really have to pay attention to. Adverse effects, really the side effects are very rare, except for death. Which is an interesting sort of a paradigm, but that's the worst outcome. But other than that, the side effects are really very rare. Everyone gets constipated, and we sort of define constipation as more than 3 days between bowel movements. Some of our patients come in and say, do you have constipation? Yeah, I do. When was the last time you had a bowel movement? Oh, I have one about every 2 weeks. Some of our patients are profoundly constipated, which is from opiates. And some of them just think that's normal too. That's because that's what it's always been like. So also thermal, a lot of patients, even when they're at their proper dose, they really sweat a lot. And it's some of my most stable patients just doing great, everything's fine, except they're just totally drenched all the time from sweat. So they try various things, and you can do, I don't know, oxybutynin, or sometimes there's certain kinds of deodorants that, or some special antiperspirant that someone said that they were told worked really well, but it's a challenge. Many of our patients also describe decreased libido, decreased sexual function. I don't know whether it's a methadone thing or a lifestyle thing. A lot of our patients gain a lot of weight, and it's not because of methadone. It's because their whole lifestyle really changes significantly when they come in. They come in from doing all the things that people with heroin addiction do, always on the move, always on the go, eating really poorly, and then many of them, if they stop using heroin, they also become more sedate, and they lay around and watch TV and eat chips. A lot of our patients really end up hiding from the world to not use heroin. And it's not a healthy thing at all, but it's sort of their way of not relapsing. It's like, because they know if they go out and they're going to see a friend or whatever, so they come to the clinic and they go home. Also the cardio issues as well. Now the QT, long QT syndrome, torsades, is not an issue with Suboxone. So that's one appealing thing for Suboxone. When we had just added, we just started doing Suboxone I should say buprenorphine naloxone as far as our OTP. And the advantages of buprenorphine naloxone in an OTP there are many. One, methadone, it can take 2 months to get to your stable dose. We can get people there in 1 week, 10 days with buprenorphine naloxone. Big advantage, I think. Another is because it's DEA category 3 instead of 2, it's less regulated, so people can get take-homes way quicker. For a person in methadone treatment, every 90 days of perfect behavior, they can come to the clinic one less day. So they're in treatment. They show up to every appointment. They're a good citizen. They have all negative UAs, and in 90 days, they can come in 5 days a week. They do it again for another 3 months, then they come in 4 days a week, etc. So it can take forever, and the least they can come in is once a month, but it takes years to get there. Suboxone, you can get there way quicker because it's way less regulated, because it's thought to have less overdose risk because of that flat level that Katie was showing us. Methadone deaths, that's changed too. It used to be when I first started there that coroner would call everything a methadone death if they found methadone in the patient's system. And we now see less of that. But we still see some of that. And when you look at methadone deaths for pain and all the graphs we've seen in the last few days, methadone is the one that's going down. Another quick aside, methadone does not show up on the PMP. Methadone from OTPs does not show up on PMP. And the reason is that we are governed by confidentiality rules, which are way stricter than HIPAA. We're governed by something called 42 CFR, federal regulations. And their standards about where the data can go and who can access it are much stricter than with HIPAA. And so that's why methadone from OTPs does not show up in the PMP. It'd be nice if it did, because it'd be nice information to have, but some people wonder why, and that's why. I don't know if you can see this. I think it's an interesting graph, but this shows basically so 2010 is the blue, the purple is 2014, the green is 2015, and this is heroin deaths going up, natural synthetic opioids actually going down a little bit in that period of time, methadone going way down. So I think it's interesting to compare this with that. And that's why I need to wrap up, almost time for lunch. But something I see is, the data says this is true, heroin deaths go up while other opiate deaths go down. And So is there a correlation to that? And there's really not much data that says that there is a correlation right now. But I also know from my own experience, I've probably met 10 patients in outpatient pain settings, when I worked in those settings recently, who said they were stable on their higher dose of opiates for their chronic back pain. They reported taking the same dose for many years, no problem with diversion or anything. This is what they reported. And they said that their prescribers were sort of mandated by somebody, or just their own fears, to taper their medication greatly. And they started using heroin for their chronic pain. And I mean, I see that. I hear that, and I know it's more complex than that, but I think it is concerning and perplexing and worrisome that as opiate prescribing decreases and as opioid deaths from prescription medication decreases, that heroin use is increasing. And what the correlation of those is, I don't know, but it seems like there may be some correlation. But there's no data yet to suggest that, so we'll see where that goes. Pregnancy. Methadone is the gold standard for a opioid dependent pregnant patient. We want to keep them in pregnancy. Many of our patients will report that when they get pregnant, their doctor says, we need to get you off of methadone ASAP, and that's false. It's completely backwards. Evidence suggests keep them in opioid treatment. Okay, so stigma. Caleb did a great job with this. I mean, how many times have I been asked, aren't you really just trading one addiction for another? Answer, no. And I'll end with this, because this I think is another interesting thing with some of my PA students who I precept have had a problem with this. They'll be like, I just don't really get it. You get patients coming in, these patients come in and they give up everything. They give up their children, they give up their families, they give up their jobs, they give up everything for this. Why would people do that? And to me, that's really backwards thinking. I mean, the answer is because that's the kind of the diagnosis of addiction. That's how you know. It'd be like if somebody said, people with pneumonia, they cough and cough and cough and blood comes up. Why do they do that? I mean, it's diagnostic. And I think some people who are new to it, even people who accept the disease myth, the disease reality, still struggle with that. How could someone do this? Okay, great. Thank you very much. Enjoy the lunch. See ya.